This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It is December 2025. Ryan, how you doing?
Fantastic. We've made it a quarter of the way through this century.
God, that's
amazing. Just think about how amazing the last 25 years have been, and there's 75 years left in this century.
Yeah. Wow.
Wow. America's in such a better place.
If AI hasn't taken over by then, we'll be doing great.
Yeah, Terminator 2 was correct, but it's just a few years early, probably.
All ends in Judgment Day. Well, speaking of that, why don't we get into these articles? Sure, we'll be talking about some AI stuff today. All right. Our first article is Diagnostic Accuracy of Point-of-Care Ultrasound for Hip Effusions, a multi-center diagnostic study. And the lead author is Rashika Jones. Children present to the emergency department with limb and hip pain fairly frequently. And unfortunately, this can range from a minor issue all the way up to a surgical emergency like septic arthritis. And it's not always easy to tell the difference between the two. But one of the things that some clinicians and experts think is identifying the presence of an effusion in the hip using ultrasound may be a way to help differentiate these syndromes. And so what these other authors wanted to look at was determine if point-of-care ultrasound performed by a pediatric emergency physician, how it compared to standard radiology performed ultrasound for diagnosing hip effusion. It was a multi-center prospective study conducted across 5 pediatric emergency departments. They enrolled children 18 or younger who were already scheduled for a radiology ultrasound due to pain in the hip. And they enrolled 161 children. The pediatric emergency physician had to be credentialed in POCUS scanning, and they used a standardized protocol which measured the distance in both hips and basically looked for the presence of hip effusion. Hip effusion was defined as a measurement of at least 5 millimeters or asymmetry of at least 2 millimeters of comparative size between the two hips. And this distance was essentially between the anterior femur and the psoas muscle. And importantly, the ED physician was blinded to the results of the radiology ultrasound scan. So they scanned 322 hips out of 161 children, and POCUS overall had fairly good diagnostic accuracy at 96%. When they looked at per hip analysis, so how they looked not at per patient, but at all the hips, POCUS had a sensitivity of 89.3% and a specificity of 99.2%. Now, there was significant variability among providers, and which they basically broke down into 2 groups. They called it high volume physicians who performed 60% of all the scans, and they achieved very good results with a sensitivity of 98.1% and a specificity of 97.8%. The remaining 15 other clinicians who scanned far less, they didn't perform quite as well. They had a sensitivity of 83.3% and a specificity of 97.4%. So all in all, I think it was a fairly well done study. I think it suggests that you can become very competent in a test like this, but it takes practice. And there's obviously variability among the providers. And the ones who do it more often are obviously going to be better than the ones who do it not as often. I think the bigger question in my mind is how good is this test at actually helping you differentiate septic arthritis from its more benign counterparts. If you look at the study, it ended up being only 2 of the patients with an effusion ended up actually being diagnosed with septic arthritis, and the rest didn't. And so I wonder if this actually does help you identify this high-risk group or not.
Well, I mean, I think what you're trying to make is a low-risk group to some extent. I mean, you're trying to rule out an effusion. And once you rule out an effusion, so much for the septic arthritis. And it's the people who do have an effusion that you already had a high clinical suspicion of, for whatever reason, that potentially need to have further evaluation or correlation with the lab results or a hip aspirate. So, I mean, I don't mind the whole only 2 of the effusions were septic, but the whole point of this whole thing is to just rule out the true negatives, basically. But yeah, I thought it was really funny, like the whole distribution of physicians. It's like there's one guy who scanned half these patients, or girl. I don't know. I didn't look at the author list. And then I like the providers could be eligible if they did like an ultrasound fellowship or like had an accreditation program in ultrasound, or they did a 1-hour course. So it's like there's a lot of heterogeneity between the people doing the ultrasound, and so I think this could be improved if they had a more uniform training and a more generalizable sort of training program, I suppose, or level of standard for doing POCUS.
But this is usually what we see with our ultrasound articles, right? There's the one ultrasound champion that like drove the article, and they do 50 to 60% of the studies and are really good. And then there's kind of a pyramid downward of, not as skilled, doing less ultrasounds, and you have less and less performance. But I mean, I think that just shows that you can get very good at this if you want to.
Well,
And the
sure.
question
I mean, we
is,
train sonographers who
right.
aren't clinicians to do these tests, for us and obtain the images. So you can be trained for it. It's just a matter of like prioritizing it among everything else that you need to be
Yeah,
competent and capable of
I
as
think
an
that's the
emergency
point.
physician.
Is it worth it, or should we have the trained stenographers doing the tests, right? And so, I
And
think
then
that's
and then offload that liability and risk to those people to some extent. You're like, how much extra liability and risk do you really want? There's already plenty of it.
yeah, I think it is an easy enough thing to be good at, that if you could just wheel this into the room and rule it out quickly versus, send them for a test and the time that takes, maybe it's worth it. But if this takes a lot of time and effort to be good at, it might not be that valuable.
Yeah, and I noticed this study had like some of the physicians were from Australia versus the United States, and there's different models of care in Australia and different resource allocations and availability. So obviously, ultrasound is generally a limited resource, so sometimes this can be important and helpful too for transferring patients from low from certain centers to a pediatric specialty hospital for that consultation. There's lots of good reasons to be good at this to exclude septic arthritis. It's just where do you fit it in? All right. A totally different topic. The next one's going to be called, but still children, derivation and validation of a clinical rule to detect bacteremia versus contaminants in positive pediatric blood cultures, a retrospective cohort study. Our lead author here is Jocelyn Gravel, and they're at CHU Saint Justine in Université de Montréal. And obviously, blood cultures can provide useful information for the ongoing treatment of significantly unwell patients. Many protocols incorporate their use. As referenced in the title, we're looking at children here, Canadian children, and these authors are trying to improve the discriminatory ability of folks dealing with a positive blood culture result. To do so, these authors went back through all their St. Justine Hospital patients for whom blood cultures were drawn, utilizing 487,000 children in whom 38,500 blood cultures were performed to obtain 747, or 2%, that popped positive. The problem they're looking at is this, that 50% of those positive blood cultures were false positives by their definition. So they went through their CART algorithm and applied a loss matrix to ensure there was a penalty, a 40-fold penalty, in fact, for missing a positive blood culture. And that created a little algorithm to guide the downstream management of patients with positive blood cultures who were initially discharged after their initial encounter. That is, approximately 1/4 of all these positive blood cultures were in patients who were actually discharged instead of admitted. And it's a pretty simple rule. If it's gram-positive in pairs or chains on the culture, and the patient was discharged home, these kids are at something around 80% risk for being a true positive, and they recommend repeating blood cultures, hospitalizing, IV antibiotics, the whole deal. If it's not either of those, but the culture comes back positive quickly, the patient has an implanted device, or there's a suspicion of an osteoarticular infection, the authors recommend returning to the ED for reassessment, repeat cultures, and then consideration of observation or hospitalization with antibiotics. None of these features, and the patient can be checked in by phone and potentially managed at home. In their little validation cohort of 173 patients, 43 of these were at home when their blood cultures became positive, and use of this rule would have resulted in a much larger cohort managed at home, as well as fewer true positives managed at home or in their observation day unit. So I think this is probably pretty fair. It's got face validity. There are still confidence intervals around their rule that will potentially miss a further excess of true bacteremia, and given it isn't perfect to start, it doesn't mean that a low-risk patient is a zero-risk patient. So that can limit the clinical acceptability in, say, the land of the free, where you're going to need a zero risk for a true bacteremia to manage a sick kid at home. But I suppose if you're in one of those sensible countries out there trying to be good stewards of inpatient resources, there's enough here to work with if you can kind of scaffold the proper safety net for the kids who are at low risk, but not zero risk.
Yeah, I really like this article. I had low expectations going in, and I really liked what they did with it. I think it's actually a quite easy to use decision rule. I don't have to do logistical regression or calculus to figure out the risk score. And as you said, it has pretty face validity, right? High risk bug, high risk patient, or high risk symptoms, right? And Essentially, I think especially when someone's on a busy shift, they get a phone call, they have to make a decision fairly quick. This is a nice way to run through it and risk stratify the patient.
Yeah, and it's a really tiny sample. It's only these physicians at this one hospital, but the rule would have improved the classification of these patients and the management of these patients, at least compared to the true management of these patients retrospectively. Still needs prospective validation, and an implementation framework, but this is very sensible.
Our next article is evaluation of out-of-hospital use of Valsalva assist device in the emergency treatment of supraventricular tachycardia. And the lead author is Andrew Applebaum. So supraventricular tachycardia, or SVT, we see fairly frequently, and often our first line approach is some sort of Valsalva, whether that's asking the patient to bear down, giving them a syringe to blow on, doing the whole revert protocol where they blow on a syringe for 10 seconds, you lower them down, lift their legs up for 10 seconds, so on and so forth. We tend to try this with variable efficacy. And so these authors were testing a new device, the Valsalva valve, which was developed essentially in an attempt to standardize the Valsalva maneuver with a simple tool that the patients can use to get the appropriate intrathoracic pressure with the hopes of breaking the SVT more frequently. And so they designed a pragmatic stepwise wedge cluster randomized controlled trial where they randomized 80 ambulances across southwestern England in essentially 4 periods. The first period, none of the stations had the device. And then each subsequent period, one of the stations was randomly assigned to either have the device or don't have the device. And they kind of had a stepwise approach where as you went from one period to the next, more and more ambulance centers had use of the device. During this period, they recruited 865 adult patients with SVT or suspected SVT. They essentially measured, and their primary outcome was essentially how often the patients were conveyed to the hospital. Now, again, they weren't really checking if the patients actually used the Valsalva device or not. It was more of a measurement of if this Valsalva device was present on the ambulance, did that have affect outcomes? And the short answer, it didn't. The actual rate of conveyance to the hospital was really high in both groups, 90% total, 89.3% in the patients who had the Valsalva device present and 89.2% in the control group. Nor did it seem to make any difference in the number of the patients who had their SVT resolved prior to arriving to the hospital or any of their other secondary endpoints. So obviously, this article has its shortcomings or its limitations. The big one being that it's unclear how often the device was used and how often wasn't. It's also unclear if all of these events were actual SVT. And so this device may be more effective than what this article is saying, but I think the makers of the device have to prove that before we start using it.
Yeah, it's kind of funny. It's like you're jumping to the end. It's like we've already deployed it. We put it on all the ambulances. And has it changed something, in just like the bigger picture as far as like cardioversion and transport to the hospital without actually building this, the sort of evidence base that this thing is more effective, and then doing like a whole like implementation and sort of cultural change and making sure people use this all the time. And yeah, there's some huge gaps here. We don't know how frequently this is used. It's just there's not a whole lot you can conclude from this other than throwing this potentially unproven device on an ambulance doesn't change outcomes.
Putting it in a drawer in an ambulance doesn't necessarily change outcomes.
Yeah, I mean, I feel like there's a missed opportunity here. They went to tons of work to do this, and I wish we knew if this was actually better or not. And again, it doesn't also say there's not a whole lot of detail into what the usual care was, like so on and so forth. Like how do people are they using syringe techniques? Are they using other adjuncts? Are they using, what are they doing here to compare it with? What's the usual standard of care? How much variability is there between ambulances? There's just so much to unpack and so much detail that we're missing.
So the Valsalva valve not dead yet, but we still don't have a justification for using it.
Yeah, I mean it's a cool looking little device. It's like a PEEP valve, It's like something you'd pop onto like your ambu bag or something like that when you're trying to like give somebody some PEEP, and it's just like a valve that releases at a certain level of expiratory strain. I don't know how much it would cost as a single use device. It's another thing for the plastic landfill, but if it prevents people from having to go to the hospital, that would be great. But it didn't here, obviously. All right, we shall move on to the next little brief article. This one is called Clinical Pathway Revision Increases Amoxicillin Monotherapy and 5-Day Durations of Therapy for Pediatric Community-Acquired Pneumonia in the Emergency Department and Urgent Care. The lead author here is Matthew Weber, and they're at the Children's Hospital of Colorado. And a few things are known. amoxicillin is sufficient for the vast majority of pediatric pneumonia diagnoses. And we've actually known for like 2 decades that, again, for the vast majority, 3 days is just as good as 5 days or 7 days. And yet, the vast majority of prescriptions for pediatric pneumonia, much of which is still viral, are for at least 7 days. These authors didn't even try to reinvent the wheel, just a baby step down to 5 days. And then also to exercise the use of azithromycin, which, yes, even in this new world of pertussis has use again, is again unnecessary in pediatric pneumonia. First, they tried the really simple option, just changing the order set default in their electronic health record to 5 days. And that was totally ineffective. And then they went through the whole process with the entire guidelines committee, changed the local clinical guidelines to directly reflect recommendations to use 5 days of amoxicillin monotherapy, integrated these pathway recommendations contextually into the electronic health record with like a bespoke guidelines thing. And then, yes, then they saw a bump in the 5-day prescribing from a whole 60% to 70%, and a decrease in azithromycin from 12% down to 3%. So, of course, this specific method of implementation will have no use outside of this specific demonstration. But right now, having heard this on the podcast about 3-day amoxicillin monotherapy, you'll all be moving just straight to that. So there's no point in this 5-day method. But anyways, mostly this is just a nice demonstration of how culture change in medicine requires a multi-pronged approach with education and reinforcement, not just moving a checkbox on a discharge order set.
I just imagine all the providers cursing that the 5-day is checked off and they have to go through it and now check.
Like, why did this order set change? This is so annoying. Somebody screwed it up. I'm moving it back to 7. But really it should be 3.
Or often 0, right? Like, as you said, a lot of this is viral. The reason
so viral. Non-severe pediatric pneumonia is viral. Anyway, 3 days, please. But at least if you're going to make a culture change to 3 days, it can't just be an order set thing. You got to update your local clinical guidelines too.
Exactly. All right. Our next article, Emerging Department Ketamine Sedation Frequency and Predictors of Critical and High-Risk Adverse Events. And the lead author is Stephen Green. So we've been using ketamine for decades for procedural sedation in children because of its risk profile. But these authors wanted to look at just how frequently critical and high-risk adverse events happen. And so using the Pediatric Sedation Research Consortium Registry, which is a multi-center database that has been collecting data since 2004, they analyzed over 12,000 unique ED ketamine encounters that met their inclusion criteria, which is essentially children under 18 receiving ketamine alone for procedural sedation. And they wanted to check the overall incidence of critical or high-risk events. And they defined a critical event as those events that are life-threatening and require immediate attention or intervention, including death. Yeah, that's pretty critical. Cardiac
requires immediate intervention for death, yes.
Death, cardiac arrest, clinical or radiological suspicion for pulmonary aspiration, allergic reaction, anaphylaxis, or any event other than the aforementioned requiring tracheal intubation, supraglottic or laryngeal mask airway, chest compressions, epinephrine, intravenous or intramuscular relaxation or paralytic agent, vasopressors, rapid response team, code team, or emergency anesthesia consultation. So I think we could agree those are fairly high-risk adverse events. And those are the critical events. The high-risk adverse events were defined as those requiring an advanced level of skill or capacity to manage and have the potential of becoming a critical event, including apnea, complete airway obstruction, laryngospasm, seizure, or any other event requiring bag malvas, continuous positive pressure ventilation, positive end expiratory pressure, oral airway, laryngospasm, so on and so forth. So again, some events that need to be paid attention to. Overall, they found a very low risk of events. They found overall of both critical and high-risk adverse events, their frequency was less than 1%, 0.54% total. The critical adverse events, or the more serious one, happened in only 2 children, so 0.016% of the encounters. One case was suspicion for pulmonary aspiration, though the child had no actual sequelae like desaturation and didn't require hospitalization. And the other one was an anaphylactic event that required positive pressure ventilation and unplanned hospitalization. So as far as the high risk adverse events, they were more frequent than the critical events, though overall very rare, 67 cases in total, or 0.52%. What they found was 41 cases of positive pressure ventilation, 36 cases of apnea, and 7 cases of laryngeal spasm. So I think all in all, this is a fairly thorough, large data registry that's been recording data for over 20 years. I think it's pretty clear here that ketamine is fairly safe when used correctly. There can be some adverse events, and obviously you need someone paying attention to the patient, but overall a very safe drug. They actually found
paying attention during a sedation.
They tried to look at like identifiable risk factors that might predict which patients are going to have a bad event, and what they found was the biggest association was when opiates were used concomitantly. So this might be a study looking at the risk or safety of opiates rather than ketamine.
Yeah, I mean, I think this is that same registry. I think I've seen analyses from these people before, and it's like people with upper airway congestion and upper airway abnormalities and syndromic children and things like that are the ones at highest risk for sedation, complications. So, I mean, that's just there's the people who have problems in sedation are fairly predictable. But yeah, I like we had a little chat with a pediatric anesthetist the other day down here. Yes, anesthetist, not anesthesiologist down here. And we were talking about ketamine sedation and laryngospasm treatment. And I was talking about how we routinely do it without intravenous access. Like I am ketamine for sedation. And at least I've done it in many practice settings. And they're like, what do you do for laryngospasm? And he's like, well, I guess you're doing intramuscular succinylcholine instead of IV. I'm like, nope, that's exactly right.
Or, just kind of bag through it.
Yeah, it turns out they don't really relax until they become like hypoxic and peri-arrest when you're just bagging through it.
See, I don't know. In my experience, I mean, maybe it wasn't Truller's, but in my experience, I've been able to bag through the few cases that I've had.
Well, that's good. But yeah, he was like, yeah, the best thing to do is just go straight to intramuscular succinylcholine and then get your IV access. And then as soon as you relax, you can ventilate because kids are trivial to ventilate. Put an LMA in, put an iGel in, whatever. And it's like you're in the green zone. I thought that was a fun discussion to have because he was like horrified by the thought of doing a sedation without intravenous access.
Yeah, I mean, I'm a little nervous by that myself.
Oh, I feel like my entire life I've done IM ketamine at multiple centers without anybody batting an eye.
For children?
For children, yeah.
I mean, I guess you could give IM ketamine and then get an IV in pretty quickly.
You could, but I mean, my son had IM ketamine for 2 LAC repairs with no IV access and no complications, but it's so safe. That's the thing. So anyways, but yeah, it's within the acceptable scope of practice to do either. How about that? All right, we'll move on to this is a chock full issue, huge podcast. You guys are loving it. Multi-center trial of the emergency department trigger tool for adverse event detection. Our lead author here is Richard Griffey, and they're at the Washington University School of Medicine. And we're back again with the 3rd Annals of Emergency Medicine publication of the emergency department trigger tool, something these authors developed from 97 potential candidate triggers in their first single center validation. And at the time, I said that I looked forward to further iterations of this important work. And here it is. I actually looked back at my old script. Going beyond Washington University, these authors applied their tool to Ottawa Hospital and the University of Michigan. And these are each sites using the Epic electronic health record platform as well. And they deployed these original 41 trigger variables across 18 months of data, representing nearly 450,000 emergency department visits. And this gave them a data set of 187,000, or 42%, trigger positive records, of which they reviewed 9,000 using dual independent review by trained ED staff, ranging from nurses to ED physicians doing the standardized abstraction. Then, like I said, this team reviewed all these flagged records to determine the presence or absence of adverse events, as well as classification in their taxonomy of type and severity. From that cohort of 9,000 from that larger 42% of cases flagged as trigger positive, 55% of them had no adverse event. And then another half of those, they found that the triggered adverse event was already present on arrival to the emergency department. So in the sum total in the end is that approximately 20% of triggered charts demonstrated an adverse event related to treatment in the emergency department. But now, again, if you don't recall our discussion in 2022, Adverse events do not mean errors or missed opportunities for timely diagnosis or intervention. Something as simple as hypotension relating to propofol administration qualifies as an adverse event, and the provision of IV fluids to treat it would upgrade it in severity to one that required an intervention. The more interesting events are very rare. Those are the ones that are patient care related with delayed treatment, failures in monitoring, etc. And those were only even 1 to 3% of all the detected patient care adverse events. The authors do note the specificity of their tool increases if their screening tool trips on more than one trigger, and they suggest this could be a further method for refining the selection of records for those most likely to contain serious adverse events. Then finally, as usual, there's a big issue jumping from academic descriptive work to useful tool with the potential to improve patient safety. The triggers, if you recall, are not geared towards specific actions, free text, or changes in patient trajectory. They simply fire off for patients blandly with abnormal physiology, abnormal lab results, who received a certain medication, or who received a certain critical intervention. There's no direct connection here between the trigger, an ED adverse event, a preventable adverse event, or preventable harms. For example, a chest CT for PE is one of the triggers. What's the likelihood of finding a preventable harm amenable to a system-level intervention by screening records with a CTPA? And then the other sort of elephant in the room. How do these findings fit in with the new transformer architecture-based tools? Are these discrete, vague triggers competitive against an LLM-first strategy? Could ChatGPT be a better screening method? Because there's a little bit more intelligence behind that other than a CTPA was performed. Or are they symbiotic? Can they combine the tool to make a more powerful thing? I think there's a lot happening here in this space, and very quickly. And this work that started back in 2017, 2018, 2019, it may actually almost becoming obsolete as it's taken so long to sort of roll out.
Yeah, stuff like this really worries me at times. This is sort of like Big Brother is watching you. And as you said, like, it doesn't necessarily mean that there was any error in care. It's just literally triggering off physiology and tests and so forth. I'm pretty sure when I have my critical care hat, almost all my patients would trigger this. And so I worry how much resources are going to have to be putting into this versus what you're going to get out of it.
Yeah, but I think this is it's more of in theory, it's not supposed to be finding places where people screwed up. It's supposed to be finding patterns of cases in which a preventable harm occurs in your institution, and saying, well, there was this whole constellation of repeated patient care problems and failures in monitoring in patients who received X. And this is like their big wide net to potentially capture that. I think the hard part is just like how much work it is. Like they're saying, oh, great, it's a 20% yield. But it's like, wow, it's still flagged 42% of their cases. So 20% of 40%, 2% of your cases is still thousands. And they say like, oh, if you only have 40,000 visits a year, that's only like 9,000 visits to review. I'm like, no. Who has the resources for that? So it's a totally valid thing to be doing some sort of patient safety auditing and have a mechanism to ensure that there's not repeated errors and repeated gaps or repeated missed opportunities for care improvement. But is this the best method for it? I don't know. It's just one way of approaching this problem.
Does it have the granularity to actually find useful information, right? Like if it tells me that, there's a bunch of patients who are getting intubated with succinylcholine and etomidate and getting hypotensive, I'm going to tell you, yeah, of course there is. That's part of what the physiology is when you're intubating sick patients. And so, is it identifying a place for improvement, or is it just identifying what happens in a hospital when you're treating sick?
Yeah, I think maybe that's probably a great way that something like this tool could be combined with some sort of reinforcement learning, where it's okay, it's flagged all these cases, and I can also see that these are all cases where there's an expected event. It's an expected adverse event because these are known effects of the treatment required for this condition, and it's not a preventable harm. And now my reinforcement learning algorithm that runs on top of this is going to say, don't flag these types of cases anymore, and then it shucks, then it takes a few more percent out of that 20% away and puts it away. And then eventually you start ending up with the cases where like weird stuff has happened and you're like, well, what's really going on here, as opposed to the predictable things.
Yeah, and I guess you could see like if it's happening more frequently than a national norm, or more frequently than your historical norm, and so forth, right?
Common element. The other trigger that we should add is Rory Spiegel's cases. We're going to review every single one of them.
All right, let's move on before anyone gets any ideas. All right, our next article is not all temperature control is equal. High quality temperature control is associated with improved outcomes following out of hospital cardiac arrest. And lead author is Rachel Beekman. Targeted temperature management has been a recommended intervention for ROS patients for years, but the results in clinical trials have been inconsistent at best. The authors hypothesized that the variability in these outcomes is due to the quality of application of the targeted temperature management rather than the efficacy of the treatment in of itself. So they conducted a retrospective study at a single academic center looking back at 421 patients between 2014 to 2024. And they created a quality score based on two main treatable factors. The first one being speed, how quickly the patient got closed loop temperature control device initiated after arriving to the hospital. They define this as door to temperature control, yet another door to blank time. And their second one was shivering management. Did this patient receive adequate adjunct medications, specifically continuous sedation, neurovascular blockades within the first 6 hours to stop shivering? And the patients were scored from 0 to 6 based on this analysis. They scored a 3 or higher. That was defined as high quality care. And obviously under a 3 was defined as low quality care. Of the 421 patients, 194 or 46% received high quality temperature control. The remainder received low quality temperature control. And what they found is you are more likely to survive until hospital discharge if you received high quality temperature control. And you also are more likely to be discharged with a good neurological outcome or a cerebral performance score of 1 or 2. So I think, on first look, this looks like maybe how you do temperature control matters, but I think just given the methodology of this paper, it's really hard to say that with any definitive certainty. It's a retrospective study. It's a single center. These identifiers that they chose to define high quality care also identify patients who are less sick. If it took you less time to get targeted temperature management initiated, maybe because you're not resuscitating, you're not doing a bunch of stuff. And then it also might have just identified patients who got better critical care in general, right? Like there's tons of confounders here. I don't think this really tells you how to do your targeted temperature. Beyond that, I'm not sure we should be doing targeted temperature management anymore at all. We have more and more studies showing that the original Bernard and Holcomb trial may have just been due to confounding in of itself. And when you find a good control group who does good critical care, it seems the temperature you pick matters less and less.
Yeah, I think that's the key is that confounder. It's people who get to their targeted temperature faster are the ones who are reaching the ICU and getting all their bundles of care and their other interventions earliest. So I think that's probably where a lot of the signal may be coming from. There's a lot of people who aren't going to let this topic die, and there's a lot of people working on like that pre-hospital accelerated like ice cap, like whatever it is type things, and they haven't given up on it, and that's great. Keep investigating the edge cases and seeing if there's an opportunity to improve outcomes in cardiac arrest. But in any event, this doesn't really move the needle for me in this paper. All right, last but not least, a quick one. Usual care for low back pain at United States Emergency Departments, 2016 to 2022. Our lead author here is Anuva Fellner, and they're at Northwestern University. And this basically just tells us what the National Hospital Ambulatory Medical Care Survey says about the care for back pain in the United States. 2016 to 2022. And as you recall, NAMCAS is a weighted sample from a handful of hospitals extrapolated to generate a picture of the rest of the country. And overall, the estimate based on their definitions of a back pain visit showed between 6 and 9 million visits annually for back pain. It dropped off considerably from the original sort of like 9 million down to 6 million during the COVID peak years through 2022. And it's not really clear what's happened in the years since, but it looked like it was starting to creep back up to the previous sort of baseline. A slight majority were female. The average age was about 45. A quarter were private insurance, a quarter were Medicare, a quarter were Medicaid, and a smattering of other status. Usually patients with back pain were triaged 3 or 4. About 14% arrived by ambulance. The mean pain score was 7. And now let's see if this sounds right. Less than a third of patients received an opioid. A tiny fraction received a benzodiazepine. A third received an NSAID. 14% received a skeletal muscle relaxant. But those numbers don't add up to 100%, which is a bit baffling to me to believe there's a significant chunk of patients who don't receive any pharmacologic treatment in the emergency department for showing up for back pain. Discharge prescriptions mirror the ED treatment. About 40% of visits received plain radiographs, 5% got a CT, and 3% ended up with an MRI. So there you go. It's an AMCAS. It's a very imprecise look at back pain in the United States, a fact further illuminated by the authors who note a prior similar review found only 3 million annual visits for back pain. So it's all in the coding, and the estimates are all in the abstraction accuracy, fairly representative of what you get by combing through government administrative data sets, a very fuzzy view at a distance.
Yeah, I don't know exactly what to do with this. The author's trying to make a reach that maybe this could be used for like developing some quality metrics and care for back pain. But like you said, there's not enough granularity here to say much of anything. And I think even if you could say these were the exact numbers and it was accurate, it doesn't really tell you what's good quality care for back pain and what's not. It just tells you what's happening in our emergency departments across the country.
Yeah, and I'm not even sure this reliably tells us exactly what's happening.
Right, exactly.
Yeah, that's one of the last articles from this month to look at.
Yeah, there's some people that show up with back pain and they get some medicine and they get some imaging, and
apparently some don't get anything.
And
seems very unlikely.
Yeah. Okay, I think that wraps us up for the month. As usual, any comments, questions, or concerns, we can be reached at annalsaudio@acep.org. Otherwise, I hope you all have happy holidays, and we will see you in the new year.